In our final afternoon session of the meeting. And we'd like to extend a warm welcome and congratulations for those of you who have continued on to the end. And I think you ought to get double CME credit for taking it all the way to the last hour. So way to go. We'd also like to thank our very generous partners who have helped make this meeting possible. The Ogden Clinic, Utah Academy of Family Physicians, and the National Kidney Foundation of Utah and of Idaho. This particular next lecture that we're going to listen to is entitled Epilepsy in Children. It'll be sponsored by Lawrence T. and the Janet D. T.D. Foundation in memory of Dr. William Riley Brown. Our next speaker and our beginning afternoon speaker is Dr. Lalitha Viswani, and she graduated from medical school in India, and she did her pediatric residency at Henry Ford Hospital in Detroit, Michigan. She had a pediatric neurology fellowship, was completed at Wayne State University in Detroit. And she's been faculty there since 2005 at Children's Hospital of Michigan, where she is the program director of the Child Neurology Residency Program. And she's been co-author of numerous publications on topics related to child neurology, including epilepsy in childhood and pediatric migraines. Her areas of research interest include complementary and alternative treatments for childhood migraine and medical education. Dr. Viswani.
Hi, everybody. It's always very challenging to pronounce my last name, so I give David credit for trying so gallantly. I think the crowds have thinned quite a bit, so we're going to be a nice, intimate group, and that's wonderful because I think it facilitates discussion and conversation. And I'm going to be talking about epilepsy in childhood today, and I would appreciate if we could maybe reserve questions, comments, discussion points towards the end of the presentation, and I'm open to talking about whatever issues may be of interest at that point. I'm from Detroit, and unfortunately the Detroit Lions are our football team, and we never seem to be doing well when there's the Super Bowl. So I'm going to show a lot of videos during this presentation. All of these videos have been obtained with parental consent, and in fact sometimes the parents themselves have sent the videos to me. So it's really interesting. I think that the iPhone and the smartphone has been one of the biggest advances in medicine, personally speaking, and I don't have any stock in Apple. So the objectives of my talk are to identify the seizure patterns that are peculiar to childhood. Seizures in children do not look like seizures in adults. They look subtle, they look different, and I'm going to be talking a little bit about treatment approaches, but I'm not going to belabor individual anti-epileptic drugs. That's really not the purpose of this talk. That's why you're going to send a child to see a neurologist to figure out which is the right anti-epileptic. I was a primary care pediatrician for 8 years, and when a family came to me with a child who they thought had seizures, their questions were, what's wrong with my child? Is this a seizure? Is my child going to be okay? And the most important question almost every parent has at the back of their mind is my child going to die? So I think these are issues which as primary care physicians probably come up frequently in practice. And when is referral urgent? Like every child who has a seizure, should we be picking up the phone at 2 a.m. and calling your local neurologist? Does every child need an EEG at 6 a.m.? Does every child need an MRI the next day? So epilepsy is obviously a historic disease, and this is a tablet from the British Museum dating back to 2000 BC, and it's really an interesting depiction of an individual who carries a cane, who is disabled, who gets around in this modified wheelchair-type device, and he had a seizure, and there are people around him indicating the dramatic nature of every seizure. Whenever a child or an adult has a seizure, it always generates a lot of consternation, a lot of excitement, whether you're in the hospital or at home or even on the freeway. People seem to get much more excited than if, say, somebody had a disease which is not so dramatic. And throughout my presentation, I'm going to be putting up pictures of people who, through the ages, have suffered from epilepsy. This is Julius Caesar, Agatha Christie, my favorite mystery author, Napoleon. And some interesting facts about epilepsy. About 500,000 children in the United States suffer from epilepsy. So every medical practice will have children with epilepsy, whether you're in family medicine or pediatrics. And a lot of internists see teenagers with epilepsy. About 20 to 40,000 new children are diagnosed with epilepsy every year. So this is a really common disease. And the best way to really diagnose seizures is by looking at the seizure. You can't diagnose the seizure by getting an EEG 2 hours later or by getting an MRI. So we really have to either look at it or get a really good history from a family member. There are different types of seizures, which we're going to talk about. And we're also going to talk about pseudo-seizures because everybody is going to see pseudo-seizures at some point or the other. So first, we're going to start with neonatal seizures. So neonates do a lot of things which are weird, what we call babyisms. Sometimes their chin will tremble. Sometimes their whole body will jerk like they're cold. And all newborns have clonus. All of us have seen that on exam, a newborn having ankle clonus. That's pretty normal. So I think the neonatal period is the hardest period to really distinguish a seizure from normal baby behavior. So this neonate was brought in saying that my 2-day-old is jittery. He tends to be jumpy, and I don't know what's going on. Maybe I should press again. No, nope. Okay, I'm trying to get the hang of, okay. So you can see in this video that the right leg of the baby is twitching and jerking in a very rhythmic manner. The nurse is drawing blood or giving something, but she doesn't notice that the baby is actually having a seizure. The right arm of the baby is also twitching. You see that? But the baby is crying, otherwise appears normal. So this is very classic for neonatal seizures. They have focal twitching. It may be just one half of the face. It could just be one arm or one leg. But neonates are not going to have generalized convulsions, the kind that adults have, where you stiffen, then you jerk, your head goes to one side, you drool, you pee on yourself, you go blue around the tongue. Neonates don't do any of that. They have fragments of that. So this is a classic example of a focal clonic seizure in a neonate. And this is the EEG of that baby, and this baby had a stroke, a perinatal stroke, a stroke that the baby suffered in utero. And when we went back and talked to the mother, she said, oh yeah, when I was pregnant with my baby, I felt the baby jerk. So some mothers can even detect seizures antenatally, even though they may not know that it was a seizure. This is a video that was actually sent to me from India. Baby stretches out, looks to the right, and just appears to stare off into space as if it's meditating or dreaming. And that's a seizure for this baby. So you can see that neonatal seizures, and this mother videotaped this, and she went to a local neurologist and then sent me the video. And as you can see, this baby doesn't have any twitching. The tonic phase lasted only for a few seconds, but what really lasted was that the eyes deviated to one side and kind of stayed there for a little bit. So this is also a classic example of a neonatal seizure. Now, how do you treat neonatal seizures? Well, I find that in practice, there's often a hurry. As soon as the neonate has a seizure, there's this big hurry to immediately start the baby on medication. Well, really, it's not starting medication that's important. It's finding out why the neonate had a seizure that's crucial. So we should be getting a spinal tap, maybe getting imaging, get blood work, do a metabolic test. That's what is important. We can start medication, but there's no hurry for that. I find it's more important to kind of let the baby have a few seizures and observe the baby and see exactly what the baby is doing. By the way, the treatment for neonatal seizures is usually phenobarbital or Dilantin. None of the newer anti-epileptics have been well studied. But one caveat is almost any neonate who's had seizures, it's worth trying vitamin B6 or pyridoxine. Now, this is a 1-year-old. We're going to proceed away from the neonatal age group. And this is a 1-year-old whose mother said that my child stretches a lot. So the grandmother said, well, maybe he's just playing. So let's see what this baby does. This baby is hooked up to video monitoring. That's what the cap is. The nurse is going to monitor blood pressure. Mom is here. There, episode number 1. Episode number 2. So that's what this baby did. So you can see how subtle this was. This was a 1-year-old who had these episodes in clusters where he would stretch out like that. These are infantile spasms. Let's look at this baby who also has infantile spasms. Now this nurse, she's going to move out of the way, don't worry. There you go. So now we have this little girl, about 8 months old. Number 1. Number 2. So you can see that, again, they can be fairly subtle. But an interesting feature of infantile spasms is, as one father actually taught me, he said, my baby's spasms happen in waves. That's a very classic feature of infantile spasms. You have 10 of these episodes, and the child is fine for 6 hours. You have 3 of the stretching spells, and the child may be fine for 24 hours. So these type of occurrences in waves is very typical of infantile spasms. Now, infantile spasms are what I consider a neurological emergency. Yes, they're not the kind of emergency as status epilepticus. Maybe they're not the same as an epidural hematoma, but they are an emergency as far as pediatrics is concerned because they can have a very poor outcome unless recognized and treated early. In fact, even when treated, many children with spasms tend to have a poor outcome. And the average time to recognition of spasms, whether it is by parents or by physicians, is about 2 to 3 months. Because many times it's passed off as, you know, the baby is just stretching, or the baby is startling, or the baby is nervous, or something along those lines. And another interesting treatment fact about infantile spasms is they don't respond to phenobarbital or dilantin or any of those classic antiepileptics. They respond to ACTH, adrenocorticotropic hormone, which is a steroid shot. And you give the baby a series of shots for about 6 to 8 weeks. Another important advance has been the approval of FDA of vigabatrin, or Sebril, which is a drug that was only available in Canada and Mexico. And since I live in Detroit, we used to smuggle it over from Canada. Not smuggle, really, but have parents bring it over from Canada so that we could administer it to our children. But now it's available in the United States. So Sebril is now a good choice for the treatment of infantile spasms. But outcome, unfortunately, tends to be poor. So early recognition is key. Now, these are potential etiologies for infantile spasms. Okay, this is a baby with tuberous sclerosis. As you can see, the hypopigmented macules, abnormalities on MRI, and this is a tuber. This is the tuber of tuberous sclerosis. Looks like a potato, the surface of a cut potato. Am I not pointing this in the right direction? Doesn't want to move forward. We're frozen on TS. Oh. Okay, so that's, while we get that up. So infantile spasms is an important neurological emergency to recognize, and to send these patients for early referral is crucial. Now, patients with infantile spasms, thank you, will often have an abnormal EEG pattern called hypsarrhythmia. It's a very chaotic, abnormal pattern. So as soon as you see it, the neurologist will say, oh, this is not good, this is not normal. So these are those children who you do want to call your neurologist at 2 a.m. and say, hey, you know what, I think this baby has spasms, because this is a child who needs to be seen relatively urgently, not be seen after 3 weeks or 3 months. Now, the important differential diagnosis for spasms is hiccups or reflux, gastroesophageal reflux, because babies with reflux do that. They kind of extend their arms and stiffen their back. And a lot of parents think it's colic, because they think the baby's belly is hurting, so he's kind of bending over. Drugs to avoid are Tegretol and Trileptal, but I don't think that's really important to know at this point. Now, we're going to look at this video of a baby that was sent to me. The baby is on the father's lap. And by show of hands, I want you to look at the video. So how many of you think this is spasms? Yeah, so this is spasms. So the baby goes, so he stretches 3 or 4 times, and then he stops after that. And this father was very perceptive. He said, that's not normal. My baby is just stretching too much. So this is a classic example of infantile spasms, and the baby was at home. So now let's move on to a little bit older age group, maybe the toddler age group. We're going to look at 2 children, and this baby has just had an event. She was eating, and then the fork flies out of her hand. It appears like she's lost consciousness, but she hasn't. She sits up right away. The mother says, shall I take away the tray from you? And she says, no. You can see her nodding her head in a minute. She appears to be a little dazed. She says, no, I don't want you to take away the tray from me. I want to eat. So there is very minimal loss of consciousness, but basically the child has objects flying out of her hand. And this is a classic example of a myoclonic seizure. One big jerk, but not in waves. You see all that in infantile spasm, it was in waves, and this is not. And this is another example of a child who will have some myoclonic jerks. So the child is very bored, yawning. Number 1. Maybe another one, number 2. So there's a little bit of clustering here, little bit, but generally the child almost is holding herself as if she's going to fall over. So this is an example of a myoclonic seizure. Now this was Florence Griffith Joyner, Olympic medalist, who had epilepsy from an undiagnosed aneurysm, and she died in her 30s from it. So myoclonic seizures, okay, frozen again. Myoclonic seizures are interesting because there is a specific type of myoclonic seizure called Dravet syndrome. And you might have listened to the recent CNN special with Sanjay Gupta, where he spoke about Dravet syndrome. And the big thing about Dravet syndrome is that these are the children who have seizures following immunization. A lot of children have seizures following immunization. But we don't pay that much attention to it. We think, well, maybe it's a side effect of the immunization. But now we know that a significant portion of children who have seizures following immunization actually end up having Dravet syndrome. And what's bad about Dravet syndrome? It's a severe epileptic encephalopathy. Most children die relatively young. They present with episodes of hemiconvulsion. So 1/2 of their body jerks for 30 minutes, 45 minutes, 2 hours. Once we had a child with Dravet syndrome where she had hemiconvulsions lasting for 6 days. And her seizures started after immunizations. And now she has progressed and unfortunately is not doing well. But that's the importance of recognizing myoclonic jerks, which can be a part of Dravet syndrome. So Dravet syndrome can start with hemiconvulsions, but ultimately you end up having these kind of myoclonic jerks. Okay. Thank you. Okay, after myoclonic epilepsy, now we're going to go ahead and, as soon as Don helps me, we are going to be looking at the most common seizure type in the pediatric age group. It's called focal epilepsy or partial epilepsy. Most children who come to you with epilepsy will have this particular seizure type. By the way, the most common seizure type in the pediatric age group are febrile seizures or febrile convulsions, for which you don't have to do anything at all. But what you're going to see right now with focal seizures is different. Yes, absolutely.
You were talking about infantile spasms being an emergency.
Yes.
I see a patient, I think they've got neurofibromatosis, whatever, whatever it is in the history of seizures. Do I have to get them to, what's the sequela if they're not evaluated quickly right now versus 3 or 4 months?
Oh, that's 3 or 4 months would not be good because many children with spasms have 100 to 200 spasms per day. The parents may only recognize 5 or 10, but oftentimes when you hook them up, they have several more. So it's important that they be recognized early so that appropriate treatment is initiated early because otherwise there could be devastating cognitive and other neurological sequelae. So 3 or 4 months would be very long. I would say the early 1 week should be the longest. Okay, so I'm just going to go back and we're going to look, okay, so we looked at myoclonic seizures and we spoke about Dravet syndrome. So that was the key point in that slide. Now the next couple of slides are little children whose parents said they laughed for no reason. My child laughs when he's just sitting there. So usually such a child doesn't come to see a neurologist. Maybe they would see a behavior specialist. But these children actually ended up seeing a neurologist. So let's see what this looks like. So there's a little 2-year-old African-American guy. That's his dad right there. There, you can see that he's starting to laugh for no good reason. The father's not tickling him. He's not playing with anything. The television, he's not looking at the television. He's just laughing out of the blue. The father thinks it's a seizure, so he goes to press the button. And now you can see the child is dissolving into tears. So sometimes a child who begins to laugh with this particular type of seizure can then begin to cry after that. So this is an example of what we call a gelastic seizure. And whenever I talk about gelastic seizures, almost invariably somebody in the audience says, well, if they're laughing seizures, are there crying seizures? Yes, there are. They could be crying seizures as well. The interesting thing about gelastic seizure is that they laugh without an emotional component to it. They're not laughing in response to a social situation. Sometimes it's almost like a grimace. It's almost like their face has been stretched out, like the Joker. Think of the Joker in Batman. So this is an example of a gelastic seizure. Which was recognized by parents. And then you're going to see what the father has sent me. This is a video that the father has sent me in which the child will begin to laugh and then turn his head to one side. And then we will see what the MRI of that child could potentially show. So gelastic seizures are, again, very typical of the pediatric age group. They very rarely start in adults or teenage years. For some reason, they seem to start between 2 and 5 years in the toddler age group, and then they kind of disappear after that. But some children with gelastic seizures end up having pretty bad neurological sequelae, pretty bad cognitive outcome. So again, early recognition is important. Another important feature of gelastic seizures is that they respond usually to surgery. And again, I want to dispel this myth that medications must be tried in patients with epilepsy before you consider surgery. That's not true anymore. There are many epileptic conditions for which surgery could be the first option, even before we try medications. And gelastic seizure is a classic example of that. So now we're going to look at little Daniel, and his father sent this video. There's a quote-unquote smile, turning his head to one side, body twisting to one side, arm stiffening up. Now the father will go ahead and show us the video of his face. You can see the child's quote-unquote smile. His face is stuck in that smile. It's almost like he can't stop doing it. And now you'll begin to see that he's going to have twitching of that half of his face. See that? Focal twitching. Even of his eye. So this is an example, again, of a gelastic seizure that was recognized by the father and the mother. And they sent this video to me thinking that maybe their child has a kind of seizure. So So gelastic seizures, as I mentioned, let's talk a little bit about the neurology of a joke. So when somebody tells you a joke, your amygdala or your limbic system has to first recognize that it's funny. So your limbic system has to say, oh, okay, I find this kind of funny. Then it transmits impulses to your frontal lobe, and then your frontal lobe actually makes you smile or laugh, and it makes you make that sound that you're laughing. So in gelastic seizures, what happens is that the seizures can arise from the frontal lobe, even though there's nothing funny, even though the amygdala doesn't recognize an event as a joke. So gelastic seizures can arise from the frontal lobe, but most gelastic seizures actually arise because of a lesion in the hypothalamus called the hypothalamic hamartoma. And if you go ahead and remove this hamartoma, either transnasally or by endoscopic surgery, it's a complete cure. They never need medications after that. Most children do extremely well. That's why you can see that early recognition of gelastic seizures can be important. Now, gelastic seizures are not new. They've been recognized for centuries. Now, let's go ahead and look at this young man who is going to be having his head and his eyes, primarily his eyes, deviated to the right. His mom is standing on the other side and calling his name, but he doesn't look at her. His eyes are kind of stuck to the right. And no matter what mom does, he doesn't look at her. His eyes are stuck to the right. So this is a classic example of a focal seizure or a partial seizure. This is the most common seizure type in the pediatric age group, a focal seizure or a partial seizure. Now let's look at another example of a child who has a focal seizure. Most focal seizures arise from the temporal lobe of the brain. And many children with partial or temporal lobe epilepsy have an aura before their seizure. The aura can be smelling rotten eggs. The aura can be seeing something like a school bus approaching them. The aura can be a funny feeling rising in their belly or a bubble bursting in their belly, or sometimes they can have a deja vu phenomenon. They say, oh, I've been in this conference center before. So many times they can feel something before their seizure. Now, this is an example of a child who said, I feel metal in my mouth. So he felt it a couple times, and after that, he would do something quite interesting. So let's go ahead and look at this little guy. His mom is sitting here in this corner. He's hooked up for video monitoring. Initially, you won't be able to see anything, but he already indicates to his mom. He said, I feel metal in my mouth. It's a little dark, but you'll be able to see it. So his mom was already getting a little concerned. She has her finger hovering over the button. She's thinking that he may be having a seizure. Then she gets up because she's pretty sure he's having a seizure. So then you can see he deviates his head to the left, and it gets stuck there. And if the pillow wasn't there, he would probably turn it even further. And she knows it's a seizure, and then she immediately presses the button. So again, this is an example of a partial epilepsy or a focal epilepsy. And some children start off having these type of focal seizures, but then they go ahead and develop whole body convulsions if left untreated, or even if treated. So this child has partial epilepsy, and this is his MRI. It's showing evidence of a dysplasia involving the right temporal lobe. This is the SPECT scan, again showing abnormalities in the right temporal lobe. This is his EEG, showing abnormalities in the right temporal lobe. The patient was an excellent candidate for surgery. He failed 2 medications, which means he's medically intractable. And that's the definition of medically intractable, if you fail 2 anti-epileptic medications. But the parents refused surgery. So he continues to have many events per day, which is unfortunate because he could ideally be an excellent candidate. So this is focal epilepsy. So the most common epilepsy in childhood is focal epilepsy, and the most common focal epilepsy is temporal lobe epilepsy. And you will see throughout the talk that Keppra or levetiracetam features as one of the anti-epileptics. I really like levetiracetam because it plays well with other anti-epileptics, with antihypertensives, with antidepressants, with migraine medications. It has very few side effects, so it's one of those drugs that you can start confidently and know that it's probably not going to make anything worse. Okay, it may not make it better right away, but it probably won't make anything worse. And there are a lot of anti-epileptics which can make certain seizures worse. Keppra is not like that. is Mary, Queen of Scots, who had epilepsy. And many times surgical resection would be an excellent choice for these children who have temporal lobe epilepsy. Just to give you a general idea, about 60 to 70% of individuals or children with epilepsy will respond to medication. That means you have 30% who are not going to respond to medication. Of those 30%, about half will respond to surgery. So that's 15%. So that's pretty big. And the remaining 15% probably not going to respond to much at all. So as you can see, intractable epilepsy is a huge problem. Many people, or a significant minority of children and adults will have intractable epilepsy. This was a slide from a patient who underwent resective surgery. These are the grids that we place on the brain before surgery. It's normally a two-step procedure. You open the skull, when you open the scalp, you put the grids on, then you put everything back. You send the patient back to their room for 5 days. You withdraw all their seizure medications. You keep your fingers crossed that they actually have seizures because you want to record seizures during those 5 days. Then on Friday, you go back to the operating room and you resect the portion from where the seizures are coming from. And people say, oh my goodness, I can't imagine my child sitting on a bed with those grids on their head. But actually, most children do extremely well. They play video games, they can eat, they can sleep, they can watch TV, they can do everything, except they have to be in that room. Kids are very resilient. Now, is temporal lobe epilepsy, what is the outcome of temporal lobe epilepsy? Well, it's about 60% at 5 years, which means that some children or some adults who undergo epilepsy, their seizures might come back. But still, on the whole, most parents and families feel that there's some improvement in their life following epilepsy surgery. So we should be advocates for early epilepsy surgery in our patients. And when we did a survey done by DuPont noted that 90% of patients were satisfied. These are 90% of patients, which means the children themselves are satisfied that they had surgery. Okay, this is, why don't we look at the video first, and then it was a teaching point for me. This is the middle of the night. The child wakes up, kicking the blankets. Mom wakes up. She thinks it's a seizure, so she presses the button. The child is also trying to press the button. She says, no, no, you don't have to do it. I already did it. And the child is just moving the bedclothes and the sheets and kicking and just being very restless, but his eyes are open. He doesn't appear to be unconscious by any means at all. And that's the end of the event. So this was a patient who came to me, and for a few years, this was a family who actually were refugees from Iraq. And so I thought that the child had some type of post-traumatic stress disorder. Maybe the child had witnessed a lot of violence, and I thought, these are something like nightmares, something along those lines. For a long time, I kind of reassured the family. I just did a routine EEG, which was normal. I said, why don't you see a psychiatrist? But then they kept coming back. So I said, just to keep the parents happy, I actually did this overnight recording. And we captured an event, and it was epilepsy. So this is frontal lobe epilepsy. Frontal lobe epilepsy is different from temporal lobe epilepsy because it's often associated with gurgling movements or gurgling sounds from the back of the throat. And also there's thrashing around of the arms and legs as if the child is voluntarily doing all of it. Unlike in temporal lobe epilepsy, you can see that the child has no control over those movements. But in frontal lobe epilepsy, it looks like the child is doing it. And oftentimes, consciousness is preserved. So, a lot of people say, well, your child was awake during the episode. What makes you think it was a seizure? But this child did have frontal lobe epilepsy, and I mistook it for a nightmare, and I thought it was maybe some type of post-traumatic stress disorder. So as I said, I really learned from this case. And levetiracetam, again, Keppra could be an excellent choice for this patient. He is on Keppra, and he's doing moderately well. So now that we've looked at different seizure types, we've looked at neonatal seizures, we've looked at infantile spasms, we've looked at partial seizures, we've looked at gelastic seizures, we've looked at frontal lobe epilepsy. So you have an idea of how varied epilepsy can look like in the pediatric age group. Now the question is, how should you investigate a child with potential seizures? So what is the role of EEG? Well, to put it in a nutshell, if you have a child in your practice who had a seizure 2 weeks ago, it's not of much benefit to do an EEG now. The best time to do an EEG is within 24 hours of the event. And many times, families don't even come to you within 24 hours of the event. And another potential disadvantage is that in most parts of the United States, there is not an EEG technician waiting in the emergency room to do an EEG on a child. The EEG department in most places works from banker's hours, 9 a.m. to 4 p.m. So you're not going to get an EEG in the middle of the night unless the patient is in the ICU. So these are some logistical difficulties. So I would suggest that if you saw a patient a few weeks ago, there's really not much point doing a routine EEG, but you might want to order an overnight EEG. That may be of greater benefit, a 24-hour EEG. So doing it within the first 24 hours is probably the most useful time to do it. Just doing a routine EEG, the pickup can be very low. It may be as low as maybe 17, 18%, which is fairly low for a test. Now, what's the role of MRI? First of all, CT should only be performed when MRI is not available. Studies have shown that children who are exposed to 2 CAT scans before the age of 12 years have a significantly higher risk of brain cancer later on in life. So, and this is a message which we as physicians really need to spread out into the community, because a lot of times families will demand a CAT scan. They say, my child had a seizure and you don't even want to do a CAT scan? And our answer should be no, because a CAT scan is not the right test for your child. Your child needs an MRI, and it can be done at such and such time. The other advantage of an MRI is that there's no radiation to the brain. The disadvantage is that it tends to be long. An MRI takes about an hour. An MRI in a 1-year-old takes about an hour and a half. You're going to need somebody who can sedate the child. A 1-year-old is not going to keep still for an hour and a half. So there are some potential drawbacks. But even if you get an MRI, abnormalities are going to be found in about 8% of first-time seizures. 92% of children who've had a first-time seizure will have a normal MRI. Of the 8%, only about 5% will have a clinically significant abnormality. Many of them have abnormalities which are okay, but nothing really causative for the seizure. Now I'm going to show you an example of a child who came into our division, and she got hooked up to EEG. The mother was a physical therapist. She had been tried on 6 anti-epileptics. She's having an event, kicking of arms and legs, flailing, covering of eyes, and she's saying, no, no, no. So this is an example of a psychogenic non-epileptic seizure, or a pseudo-seizure. And as you can see, this looks very similar to the frontal lobe seizure that we saw. You know, they both had kicking of their arms and legs. They both said things or made, sounds from the back of their throat. They both had preserved level of consciousness. So you can see how psychogenic non-epileptic seizures can mimic epilepsy. And of children referred to pediatric neurologists, about 20% can have psychogenic seizures. Nowadays, we recommend that you use the word psychogenic non-epileptic seizures and not use the word pseudo-seizures. It's probably maybe politically more correct. And these are classic features of pseudo-seizures. Pelvic thrusting. I found that pelvic thrusting is a very classic feature of pseudo-seizures. And sometimes families will say, well, she urinates during a seizure. Doesn't that mean that it's a true seizure? No. Many children with psychogenic non-epileptic seizures will urinate during a seizure. They almost will never have a bowel movement, but they will urinate. Another interesting distinguishing feature is that during a true seizure, usually your eyes are open. During a psychogenic seizure, many times your eyes are closed. So there can be some distinguishing features, but the only way to really find out is to hook them up to that EEG. And most psychogenic seizures happen when there's an audience, when there are people around. It almost never happens when the child is all by herself in the room. And an important association of P and ES is with sexual abuse. A recent paper has noted that over 50% of children who have psychogenic non-epileptic seizures have a history of sexual abuse when they were younger. So that's an important aspect which physicians should be aware of. So psychogenic non-epileptic seizure. So what happens when you tell a family that your child has PNES? First of all, they're going to be mad. They're going to be angry with you because you conveyed this piece of information to them. So they often react with negativity to the diagnosis. So it's important to say it in a way that families understand. And the child is really not faking or pretending. And a lot of medical personnel, including EEG technicians and nurses, think that the child is faking it. Recently, we had a child who was having a psychogenic non-epileptic seizure, and the nurse who was next to me said, well, she has it down pretty good, doesn't she? Well, she's not doing it. It's not malingering. So that's important to recognize. Clinicians are very uncomfortable with this. All of us have a great degree of discomfort conveying this information to families, and the treatment is anti-anxiety medications. Now let's quickly move over to some treatment options for epilepsy. So these are the treatment options. I think it's frozen again, Don. These are the treatment options for epilepsy in the United States: drugs, diet, vagus nerve stimulator, and surgery. These are the accepted treatment options in the United States. Let's first talk about the diet. This ketogenic diet has been around for centuries. There have been scriptures where people have said that I prayed and fasted over my child who has seizures. That's what the ketogenic diet is. You're fasting the child so that the child has ketones. Prayer would probably help as well, but nonetheless, that's the basis of the ketogenic diet, fasting. So your body makes ketones. The ketogenic diet was initially started in California at Loma Linda since the 1930s, and it's a very effective treatment option for epilepsy. In the past, the ketogenic diet consisted of a very high-fat, high-protein, very low-carb diet, which wasn't very kid-friendly. For instance, so we're talking about the diet, and this was an example of a keto platter that you would get for breakfast. You would get eggs and cheese, you would get one strawberry, you would get a pat of butter, and you would get a single strip of bacon. So this is not a very kid-friendly diet. But nonetheless, now we have better options for the ketogenic diet. We have keto shakes. This is an example of an Atkins keto shake that a family could buy and give to their child. You can make peanut butter cups using special formulas. You can bake a cake for your child's birthday, even if they're on the ketogenic diet. And studies have also shown that the modified Atkins diet is as effective as the ketogenic diet in the treatment of epilepsy. And a lot of people are very familiar with the modified Atkins diet. So that's another thing which I think as physicians we can convey to our families, that is not just medication. Diet can be a useful adjunct as well. In fact, I have quite a big group of families who say we don't want medication, we just want to do diet. The diet is very time consuming. You have to weigh and measure calories for breakfast, for lunch, for dinner. So it's really hard, but for a dedicated family, that could be a great option. Another option is called the vagus nerve stimulator. The vagus nerve stimulator is a device that you place beneath the muscles of the chest, and we're going to see what it looks like. So this is one of our nurse practitioners, and she's going to interrogate this child's vagal nerve stimulator. As you can see, you can't see it. So you put it right over the device, doesn't hurt at all. It transmits the necessary signals to this little smart pad type device, and then you can make whatever adjustments you need. A similar device is also given to the family and sometimes to the school teacher. So when the child has a seizure, they can swap that over their device, and that can stop their seizure. A lot of families like this. It gives them some control over their child's seizures. And there you go. That's all the information. So what does this VNS look like? That's what it looks like. The VNS is really small, a little bit bigger than a quarter, weighs a few ounces, and once you have it in place, it doesn't hurt at all, and there are no restrictions. So I think that's a good option for families who do not want to have epilepsy surgery. Now, we spoke about drugs, we spoke about diet, we spoke about the vagus nerve stimulator, but everybody wants to know what is the role of medical marijuana in epilepsy. I get at least 2 or 3 calls every week. They want their child to be on marijuana, they've identified a grower, they have the right leaves, they're ready to make the oil or put it into the child's food. They have a vaporizer. They just need a physician to sign off. So what should we be doing as a medical community about this? Well, I think this really came to light with the recent CNN episode where Sanjay Gupta was interviewing individuals about the role of THC and cannabis. And the American Academy of Neurology, fortunately, has put out a statement paper, and they have said that the role of medical marijuana in epilepsy is unclear. So we should probably not be advocating for it, but the question is, should we be neutral or should we be discouraging families? And I would like to hear people's opinions as to what you practice here. So obviously, cannabidiol, which is CBD, is not new. This is a papyrus script from 1600 BC, where they describe the use of cannabis for epilepsy. So it's nothing new at all. It's been around for centuries. It's a question of societal acceptance and a question of how effective is it? What's the science behind it? Are we just going to give it to a child, or are we going to really find out how it works? And oftentimes, I do see clinics like this springing up. And this is an advertisement from the 1920s where people were selling cannabis for epilepsy. And this is, of course, the cannabis plant. So I was just looking at what the different states did, and I'm from Michigan, here in the blue. And in Michigan, we do have laws governing the use of marijuana in children. And just recently, we had a family who started using marijuana for their child with Dravet syndrome. Remember, we spoke about Dravet syndrome? It's a horrible epileptic encephalopathy. So the mother decided to stop all 5 seizure medications. She also tried the diet, did not work, so she stopped that as well. And now the child is using inhaled, with the help of a vaporizer. She gives the child, the cannabis 2 or 3 times per day. Here in Utah, we don't have laws as yet governing medical marijuana for children, which is in a way good for us. For those of you who practice here, because you can say, hey, we really don't do it at this point. But it will be coming, that's for sure. So what should you do when you see a child with a first-time seizure? This is kind of my suggestion for primary care physicians. So I say, is the child sick? Is the child febrile? If the child is sick but otherwise looks well, that's a febrile seizure. Do nothing. Reassure the family. You can give Diastat, which is a rectal suppository. You could do that for as and when used, but this child doesn't need to be on seizure medication. On the other hand, if the child is not febrile, this is an unprovoked seizure in a child. Then if the child looks well, you get an EEG if it's available. You can order an MRI as an outpatient, but we don't start anti-epileptic medications. We almost never start anti-epileptic medications at the first seizure. Usually we wait for 2 or 3 seizures because not every child who's had 1 seizure will go on to have a second or a third. On the other hand, if the child doesn't appear well, the child is somnolent, confused, one side is still weak, the child has a 40-minute seizure, well, obviously that child needs to be admitted and needs immediate EEG and MRI. So this is kind of the way I approach a child with seizures. So what about the law about driving? In Michigan, the law is that you cannot drive within 6 months of having a seizure. And a lot of teenagers will not tell you that they had a seizure because they want to drive. So it's important to ask and verify with the family. But seizure-related accidents are very low. They only account for 0.2% of all fatalities. Most fatalities in teenagers are related to use of alcohol. So what about SUDEP? When I was a pediatrician, I felt a lot of discomfort discussing this condition called SUDEP, which stands for sudden, unexpected, or unwitnessed death in epilepsy. First of all, I asked myself, is it my role to discuss this with the family? Is it not the role of the neurologist? But then now that I'm on the other side, I feel that everybody who is involved in the well-being of the child should be aware that a child with uncontrolled seizures, a child who is neurologically not normal, for instance, a child with cerebral palsy, or a child who is on multiple seizure medications can pass away suddenly, and usually it happens in their sleep. Now, people are going to say, well, it's rare, so why should I discuss it with my families? Well, the incidence is about the same as the incidence of SIDS, which is sudden infant death syndrome. So we discuss SIDS all the time. We're open about it. We talk to families about it. So I think that SUDEP should also be discussed with families, and it should be mentioned in the right setting. So you don't have to talk about SUDEP if the child has febrile seizures. You know that's not going to happen. But if a child has underlying neurological problems, and if the child is on a lot of seizure medications, not responding, I think it is our duty to inform the families about SUDEP. Okay, so do people with epilepsy have a higher risk of injury? Absolutely. So I like to give them some pointers. I say, well, avoid well, if you're in the kitchen, try to use the back burners. That helps when they cook. Turn the handles of the pots on the other side. Use rubber gloves when you're washing the dishes because the water gets really hot, and if you have a seizure, that could be very dangerous. In the rest of the house, I say try to have chairs which have handles on them, so when you have a seizure, you don't fall off. Try to have carpeting in every room of the house, especially in areas where you traditionally don't have carpeting, such as the kitchen, because if you fall down and have a seizure, that could be dangerous. And it's also very important to tell children with epilepsy that they should avoid being in a bathtub by themselves. Avoid swimming by themselves. So these, I think, are important situations. They can take a shower by themselves, that's fine. Most children with epilepsy can go on roller coaster rides, that's not a problem. They can watch video games, they can go to movies, that's usually not a problem. So avoid the tub and keep the water in the tub at low levels. And usually, if it's a child with really bad epilepsy, I will suggest installing a shower seat and give the child some independence, some privacy. So conclusions are most children with epilepsy do outgrow their seizures, and that's different from adults. Most adults who have epilepsy tend to have an underlying disorder as a result of which they tend not to outgrow. But the good thing about the pediatric age group is that they do outgrow their seizures. And the treatment options are many. It can be medications, it can be diet, it can be surgery, and it doesn't have to be in that order. And many children who have epilepsy and who come into the clinic, it's normal, I think, as physicians, we want to go through our checklist, or if you have an EMR, what medications are you on? What are your side effects? When was your last seizure? But the older children get, sometimes their concerns are different from yours. Recently, I had a boy who has intractable epilepsy, and I said, well, is there anything else you'd like to talk about? He said, if I have sex and if my girlfriend gets pregnant, will my epilepsy be passed on to that child? So children do think about things other than just what is their seizure medication and when was their last seizure. So now I realize it's important to ask open-ended questions. What would you like to talk about today? And a lot of children with seizures have comorbidities such as depression and ADHD. The most common comorbidity in children is ADHD. So a lot of children with epilepsy need to be on stimulants such as Adderall or Ritalin. And no, they don't make seizures worse. So I would like to conclude by showing this video of a child. It looks a little dark, but it's going to work. And you're going to be able to see a movement. And this is also a video which was sent by a family. Child is otherwise well, but does this kind of weird movements of the mouth 2 or 3 times per day. Can you see that of the mouth? Oh, maybe now. There, she's going to do it now. There you go. The child does that many, many times per day. So first they sent me the video and I said, I don't know, looks like baby stuff. I don't know, doesn't look like a seizure. So then I hooked him up, and fortunately for me, it wasn't a seizure. So I looked good to them. So that was great. I think that was my last one. And if anyone has any questions, if anybody has any opinions about use of medical marijuana in Utah, please discuss them. No questions? You have a question? Yes, ma'am. Oh, that's okay. You can speak up. I'll repeat your question.
I appreciate it. It was a great talk. I appreciate talking about febrile seizures briefly. When a child gets more than one febrile seizure, can you talk a little bit about how we manage that?
Sure. The question is, what if a child has multiple febrile seizures within 24 hours? If it's within 24 hours and a child has 2 or 3 febrile seizures, we treat it the same way as if it was a single febrile seizure. So multiple seizures in 24 hours is about the same as single seizure. What if a child has febrile seizures at 6 months, 8 months, 10 months, 12 months, 24 months, and 36 months? That's still okay. That's still okay as long as the seizure is short, short meaning less than 3 minutes or less than 4 minutes. As long as the child is developing normally, I would not put that child on seizure medication. And contrary to public opinion, I would not obtain an EEG or an MRI because God forbid if there are abnormalities, then you're going to be stuck in a position where you have to explain that to the family. Yeah. But if a child has very prolonged febrile seizures, 30, 40 minutes, if they involve one half of the body, then I begin to get nervous because then I realize it's not typical febrile seizures. Okay, that's a good question. So if a child has febrile seizures and the onset is less than 2 years of age, the child will probably continue to have more febrile seizures till they turn about 5 or 6. So that's almost a given, so you can tell families that. But if a child has uncomplicated febrile seizures, the chance of developing epilepsy is extremely low. It's almost the same as the general population, as long as the child is not having prolonged febrile seizures. That's a very good question. Thank you. Yes, sir. Yes. Yes. Migraine and epilepsy are comorbid with each other. Yesterday, Dr. Kerr gave a talk on migraine. Having epilepsy places you at a 2 to 3-fold higher chance of having migraine, and having migraine places you at a higher risk of having epilepsy, though not to the same extent. Usually, when I have children who have epilepsy and migraine, I will treat them as if I would treat any other child with migraine. I use triptans quite a bit, max salt, sumatriptan. I use naproxen. And usually, the two don't have a one-to-one relationship. Just because your epilepsy is poorly controlled doesn't mean that your migraine is going to be poorly controlled. So I treat them as two individual entities. But sometimes it's important to ask, because some children think that their headache is a seizure, but it's not. It's migraine. Yes. There are certain migraine is a polygenetic condition. There's a familial basis, maybe there's an environmental basis, and it's a very common disease. 20% of women in the United States have migraine. So by sheer coincidence, some of those people will have epilepsy. And certain types of epilepsies run in families, but there's no specific syndrome where migraine and epilepsy together runs in a family, to my knowledge. But they're both extremely common, so there's going to be some overlap.
Do we have time for one more question?
Hello.
I'd always understood that having prolonged or multiple seizures was bad for your brain.
Febrile seizures or afebrile?
No, any
afebrile.
Yeah,
okay.
Epileptic type of seizures.
Okay.
So how long do you give patients a trial of medication or food therapy before you decide to switch to another treatment option? And you seem to also indicate during your talk that at least in kids, not doing anything for a while is okay. At what point do you feel like it's important for them to get definitive treatment for the...
Well, thank you. I'm going to answer them in the reverse order. So when should a child who has unprovoked seizures be started on medication? Usually following a first unprovoked seizure, I would obtain an EEG at a reasonable time, preferably a 24-hour EEG. I would obtain MRI, and if both look normal, then I would wait if the child is otherwise healthy and normal. If the child has 2 seizures, the EEG is still normal, child is still doing well, I'm going to be leaning towards starting antiepileptics, but definitely at the 3rd unprovoked seizure, I would start antiepileptics, because at that point, the chance of you having number 4, 5, and 6 are much higher. Now, your other question was, at what point should you consider other treatment options? Well, most physicians in the United States feel comfortable with medication. That's the way we've been taught here. That's what has been passed on. And it's not the same in other parts of the world. But nonetheless, medication is normally what we normally start with. So we start with drug number 1. If that fails, we go to drug number 2. But when drug number 2 fails, you begin to feel, oh, this may be a little bit difficult. So in practice, normally we do try drug number 3, but at that point, you're already working the child up for epilepsy surgery. You're suggesting other options, such as the diet or the vagus nerve stimulator. Some parents are more agreeable to it than others. Usually, I will try diet before I do the vagus nerve stimulator, because the vagus nerve stimulator is an actual device you're putting inside the child's chest. And whereas the diet, it's not that invasive. So usually I'll try diet first. So usually I'll do 2 medications. If that fails, I will do diet/surgery, then vagus nerve stimulator. And I usually don't advocate the use of cannabis unless I'm forced to. Okay, that's a good question. That has been well studied. And it has been found that if you use the anti-epileptic at the right dose, and if it is the right anti-epileptic for that seizure type, you're going to know fairly quickly whether it's working or not. Many times I find that there is underdosing. It's not the right dose for that child, or the medication itself was not chosen appropriately for that seizure type. So you have a child with infantile spasms, and the child is on phenobarbital. That's not going to work. So it has to be the right medicine and at the right dose. And usually in pediatrics, especially within a few months, you're going to know whether it's working or not. So by the end of about 6 months or 8, 10 months, you know whether these medicines have worked or not. You don't need years and years of treatment to say, oh, well, maybe it's time to try something else. All right, well, thank you.